Good morning and welcome to a talk regarding the management of nausea and vomiting, mucositis and diarrhoea. For those of you who don't know me or recognise my voice, my name is Nikki Knightley and I'm the bone marrow transplant ACP. So the aim of the session today is to talk to you about common side effects of patients who have undergone high-dose chemotherapy for stem cell transplantation. These side effects are also relevant to the majority of the patients undergoing intensive chemotherapy on the inpatient unit. And as you can see from the lovely diagrams, I'm going to talk to you specifically about nausea and vomiting, followed by mucositis, and then finishing off with diarrhoea. So I'm going to talk about these side effects from really the perspective of a healthcare assistant, and also what you can do to support patients who are struggling with these specific side effects. So to start with, we're going to talk about nausea and vomiting, and what I'd like to do is just break down what that actually means. So nausea is defined as the kind of subjective urge to vomit, whilst retching is the laboured movement of the thoracic and the abdominal muscles before we actually vomit, and then vomiting is the forceful expulsion of the gastric contents, which is coordinated in the emetic centre. So when we're talking about chemotherapy-induced nausea and vomiting, there are kind of different ways that can occur. And what you're probably more commonly used to is what we call the acute vomiting. And this usually occurs within minutes or up to about 24 hours after drug administration. Its intensity usually peaks about 5 to 6 hours later, but it usually resolves within about 24 hours. And this is because it's the stimulation of the neuroreceptors. We don't commonly see this with transplant treatment chemotherapy, primarily because we choose to give a strong regime of anti-sickness medications prior to giving chemo, which will hopefully reduce the risk of them having these acute episodes. However, what we do often see is delayed nausea and vomiting, and that usually occurs up to 120 hours after the chemo, but it usually peaks after 3 days, so around 72 hours. This can generally last up to about a week after chemo, and the exact mechanism of this is not completely clear, whether it be some kind of rebound effect or whether it's kind of direct action of the drug. But it's really important that early control happens. And again, that's why we give pre-medications of antiemetics, but it's also why we encourage patients to inform us sooner rather than later if they start to develop any nausea or vomiting in the coming days after chemotherapy. So if we just move on to the bottom now, we will look at anticipatory nausea. And this often occurs in that group of patients who've had a previous bad experience with nausea and vomiting. So it may be they've been really sick with previous chemos, or it may be that we've just had poor control of their nausea in their previous treatment. It can often be triggered by taste or odours or memories. So if they've eaten something that's made them sick previously, and then they're given that food again, that could trigger that memory. It's kind of a conditional reflux, but it's also more common in those patients who've got a history of anxiety and depression. And then finally, we've got the refractory nausea and vomiting, and this occurs in kind of subsequent treatments of cycles where previous treatment has not been beneficial. And this is common really in kind of 30 to 50% of our patients. And I think that works in conjunction with the anticipatory nausea that we often see in these patients as well. So I just want to talk about what the patient-related factors for having an increased risk of nausea and vomiting. And we've touched on that briefly on the previous slide, but what we do know is that nausea and vomiting is more common in women. It's also more common in men and women over the age of 50. And if you think about the patients we treat, a lot of those patients are over that age group. And, you know, so it's just really important that we acknowledge that. It's also, as alluded to earlier, more common in those patients who've had a history of anxiety or depression, or they're really stressed about their treatment, or, you know, they've got a recognised fear. And I think for most patients coming in for transplant treatment, this is fear of the unknown, and that can impact on their levels of nausea and vomiting. And we also know, as previously said, that those who've had a history of nausea and vomiting are more likely to suffer with transplant treatment. So what are the causes of chemotherapy-induced nausea and vomiting, particularly in transplant? Well, we're giving patients a high dose of chemotherapy, higher dose chemo than they will have had with previous cycles of treatment. We know that patients are pre-treated, so they've often got this anticipatory feeling and worry about being sick, particularly if they've had a bad experience. We know that different transplant types require different chemotherapy regimes. So if you compare the patients having myeloma treatment, that would just be a 1 day of Malphilan, whereas a patient who's having beam chemotherapy, so usually used for lymphoma patients, they're having 6 days worth of chemotherapy. So therefore, it's not rocket science that they're more at risk of nausea and vomiting. We often give patients a lot of antibiotics while they're in, whether that's to start with, just to prevent infections, but also if they do develop a fever and develop an infection, they will be on intravenous antibiotics, which can in itself cause people to feel nauseous. Patients are often on analgesics, particularly if they're myeloma. They've usually presented prior to diagnosis with things like back pain or rib fractures, and therefore they're usually on high doses of pain relief such as morphine or things like tramadol, and for some people even paracetamol or codeine can make them a bit nauseous. And then you've got neutropenia. For patients who are neutropenic, their whole immune system is depleted, and that in itself can make them more susceptible to things like nausea and vomiting. So with patients, prior to coming into transplant, but also while they're in, it's all of our jobs really to encourage self-help. So what we talk to patients about is eating prior to treatment, but also once they've had their treatment, we know their appetite reduces, and I'm sure at some point all of you have experienced some kind of vomiting bug, and then you start to feel more sick because you don't eat. And we know by just eating small amounts of food, that can actually reduce people's feelings of being sick or feeling sick. Sometimes chewing gum or pastels, or kind of fruit pastels, can be really helpful. Relaxation and distraction techniques, that's another really good way to kind of address people's feelings of nausea. And as I said earlier, encouraging patients to report their symptoms. Early reporting of symptoms really helps us manage and get on top of how they're feeling. And the longer they leave those symptoms, the much harder it is for the nursing and medical team to get on top of the symptoms with medication. I've already mentioned this, but we do give a good range of anti-sickness medications. Years ago, we would wait for people to be sick before we gave them antiemetics, but now we give that up front. And we have a whole toolbox full of anti-sickness in line with the SOP. And if one doesn't work, then we can try another one. And if that doesn't work, there's generally 3 or 4 options available. And really it's about being alert to signs and symptoms. They need to know signs and symptoms of nausea and vomiting. What should they expect? What's not normal? And again, just reiterating that importance of reporting those symptoms. And then in relation to environment, I suppose that's really when they're on the ward. Most patients will report the smell of the food makes them feel sick. And I think it's much better these days as we don't have an actual food trolley coming to the ward and meals being dished up in the corridor like they used to. But I think it's just having that awareness that sometimes patients lift the lid off the plate of food and that's enough to make them feel sick. And more recently, I've had a couple of patients who've suggested to me that just knowing their ice lollies are still in the fridge in their room makes them feel sick. So it's just being mindful about little things that can make a big difference. So if you're in with a patient and they are feeling nauseous, you know, just ask them, did you have any ice lollies? How did you find that? Was it helpful? How are you feeling about it now? And it may be having another ice lolly might help because it's cold and it's giving them a bit of kind of sugar in the system. But equally, they may say to you, the thought of another ice lolly makes me sick. And at that point, that could be your kind of be your way in to say to them, would you like me to remove the ice lollies out the freezer? And I've done that for patients and they have said it makes a difference. So really our job is always to be looking for signs and symptoms of what we can do, but it's also about supporting patients to make small changes themselves to kind of aid that self-help, and also for them to take a bit of ownership back on managing their symptoms. So just to move on really, what can you do? So I feel like a lot of education and information provided is directed at medical staff and nursing staff, but actually I think as healthcare assistants you play a really big role in managing patient symptoms and having the time to talk to them while you're doing things like washing or making their beds, about what it is that might help them, but also about communicating those conversations with the medical team and the nursing team, because often those things don't happen just because of how busy people are. So as a healthcare assistant, what is it that you can do to help patients who may be struggling with nausea and vomiting? So this diagram really just breaks it down into 3 sections. So if we start at the top and talk about mouth care, we know that when people are sick, they often expel acid contents from their stomach, and this often coats the mouth, particularly the teeth. So it's really important that if patients are vomiting, that you support them with brushing their teeth or using any mouthwashes that may be beneficial at that point. And that really just helps protect the mouth hygiene, but it also helps patients feel a bit fresher after they've actually been sick. So moving on to hydration, often, even if patients are not being sick, if they're feeling sick, it really puts them off doing a number of things. It puts them off doing the mouth hygiene, but it also puts them off drinking and eating. And we know with transplant patients it's really important that they drink 2 to 3 litres of fluid a day, and that's for a number of reasons. One of those is because of the increased risk of diarrhoea, which we'll come on to a bit later, but also the majority of transplant patients will get a temperature at some point, and when they've got a temperature they lose fluid through their skin, through their sweat, but also their body is working that much harder because it's trying to fight off a temperature and an infection. So from your point of view, the really important things you can be doing is just encouraging oral fluids, you know, checking in with patients, making sure that they are drinking, making sure fluid charts are being filled in. And often our patients will do this themselves, but particularly when they are feeling unwell or they've got a temperature or they're feeling really sick, the last thing they want to do is be doing a fluid chart. So just, you know, as you do already, but just being really mindful of just making sure those fluid charts are filled in. They're a vital part of our assessment when we're looking at whether patients require intravenous fluids. And it's not just the input that needs to be recorded, it's also the output. And we just need to be really, really sure that patients are getting enough orally. And if they're not, then it's about really looking at whether they need to be started on intravenous fluids. And it's really helpful for you as healthcare assistants who are doing tea rounds, who are, you know, in and out of patients' rooms, supporting personal care, changing their jugs of water, that you just really just keep an eye on what the patients are actually drinking, and again communicate to the nursing staff if you're concerned, and never be afraid to say, do you think this patient might need intravenous fluids? And then the third thing on that list down in the purple box is that about nutrition. Again, it's really important that we monitor what patients are eating. They are seen regularly by the dietitian, but we also know that when patients are nauseous or being sick, that they don't eat. So it's about really just assessing that a patient is an individual. If you are collecting menu choices, or you are delivering meals, or just generally chatting to patients, what is it they like to eat? What, have they gone off hot food, which most patients do? Do they want to look at a different type of menu on the ward? And I think we're really fortunate that there are lots and lots of menus available. But one of the things patients feed back to me most inpatient stays is the presentation of the food, or that the portion sizes are too big, and they'll take the lid off the tray of food and they just put it straight back on again. So it's just really trying to consider for that individual patient, what can you do as a healthcare assistant to help them maybe at least try and eat something else. And if they don't fancy a meal, do they just want a piece of toast? And I know you guys are great now with the snacks that are available and offering those to patients, but it's just really about trying to encourage small meals or small snacks little and often. It doesn't have to be, a big meal. It could be a couple of biscuits, and then a couple of hours later they have a couple of chunks of cheese, or an hour after that they have a glass of milk. It's just looking at different ways. And if they're not eating but they can tolerate milk, would it be worth considering putting a pint of milk in their fridge in their room so they can have that as and when they feel necessary? So I'm just going to go on and talk about mucositis. So mucositis is really occurs because of the effects of chemotherapy, and it's the generic term for the inflammation and ulceration of patients, not only their mouth, but from their mouth right down to their bottom, which can occur due to the effects of chemotherapy, or in some terms radiotherapy. And the reason for this is because it interferes with the normal turnover of the cells, which causes injury to the mucosa. And as I said earlier, it can occur anywhere along the GI tract, but most commonly we see inflammation and ulceration within the mouth. So mucositis can cause a whole host of complications, and with transplant patients we usually see that around probably day 7 post chemotherapy, and that's because it generally takes chemotherapy about a week to cause the most damage. So the complications we see because of mucositis is generally initially ulceration. So it may be patients develop a sore throat, or they develop actual mouth ulcers anywhere within the mouth or in the throat. It often causes taste changes, and most patients will say food just doesn't taste of anything, or it tastes of cardboard, or I just don't want to eat it because my mouth's sore. It can cause bleeding, it can cause pain, and in some cases it can cause infection, and that may be a bacterial infection, but it can also be fungal infections, things like thrush. And then in turn, all of those things can then cause this inability to eat, because patients feel like they just physically can't eat anything because it hurts to swallow so much, or their mouth is incredibly dry or incredibly sore. And I don't know if you've ever had a mouth ulcer, most of us have, but even just a tiny ulcer can feel like a huge ulcer within your mouth. And in turn, all of those things can then lead to malnutrition in our patients. So risk factors for developing mucositis. So there are a couple of things. If we just start with the patient, we know that age and gender can impact on those that are more at risk of mucositis. Often, again, females and those of an older population. Type of disease, that will determine the type of treatment that patients have. What their initial nutritional status is. If they've got poor nutrition anyway, then they're more at risk of developing mucositis. If they've got poor oral hygiene or oral care or pre-existing oral problems, that will also increase their risk of developing mucositis. And then from a treatment perspective, the drugs we're giving, so as I said earlier, those patients that are just having Malphalan, yes, it's high dose chemotherapy, and yes, they will get side effects, but for those having BEAM and getting a 6-day regime of chemotherapy, they are more likely to develop mucositis because they have an increased amount of drugs, but also the doses can vary from patient to patient. In patients who are maybe a bit older or have got abnormal kidney or liver function, they may be dose reduced, whereas those patients that are younger or fitter, they will have full dose and therefore more likely to pick up side effects or worsening side effects. And of course, all of our patients having transplant chemotherapy will become neutropenic, and once they're neutropenic, they have the inability to fight off any infections, but also the damage from the mucosa is more likely to become infected because they don't have that immunity. So what are the signs and symptoms of mucositis? So as I said earlier, often the first sign that patients express is pain, and that may be a bit of a sore throat, or it may be that they complain of an ulcer. Often patients then describe it difficult to swallow, and again, putting yourself in the patient's shoes, we've all had a sore throat and felt it's like swallowing razor blades. It may be that they have altered taste. It may be that they have bad breath. They have a very dry mouth. They're unable to make saliva, or that they've developed bacterial or fungal infections. And symptoms can occur on day 4 to 5, but I think recently my experience been, as I said earlier, more like day 7, and they usually last for about 10 days. And this is when the neutrophils start to recover and the body starts to recover from the effects of chemotherapy. So again, what can we be doing? And I think all of us are responsible for this, whether we are a doctor, a nurse, or a healthcare assistant. We look at mucositis and we use the World Health Organization oral toxicity scale for grading that. So you can see along the top of there is grades 1 to 4. And underneath those are some pictures, really, just to give you a bit of an idea of what the grading score looks like. And in an ideal world, patients would all have a maximum of a grade 1, but I think we can probably think of patients who have had at least 2 and 3, if not 4. And I think, again, when you are talking to patients in their room and they're telling you their mouth's a bit sore, there's nothing wrong with you asking to have a look in their mouth and then liaising that with the healthcare professionals looking after them from a nursing and medical perspective. So there are lots of things we can do to prevent mucositis, and I'm going to start with the good old ice chips and ice lollies. They are what we recommend for all patients who are undergoing chemotherapy at transplant. And the reason for that is a number of studies were done many years ago now, which showed actually if patients suck ice lollies or ice chips, the blood vessels within the mouth and the oral mucosa constrict, and that stops the chemotherapy getting to those fast dividing cells. So you will have seen many patients on the ward sucking ice lollies, and we recommend they start this at about 30 minutes before chemotherapy and they continue for about 30 minutes after. So it's usually about 1.5 to 2 hours. And in my experience, patients sucking ice lollies makes a huge difference to the mucositis levels that they get. We know that patients need to have good nutritional oral intake, and that again can help with the recovery, but also with the severity of the soreness in the mouth. We need to make sure that they've had good education, and we do that as part of the pre-transplant talk, with regards to bringing in a soft toothbrush, but also bringing in things like Vaseline to keep their lips moist. We ensure they've had a dental assessment pre-admission, and if they need any extractions or any dental work doing, that's been completed. They will have their mouthwashes that they're given and prescribed on admission, and we also encourage them to remove any dentures, particularly if they're developing ulcers. So again, it's about reminding patients to take a bit of self-ownership and, you know, as much as they can, do all of these things. So before I flip to diarrhoea, I think just to touch back on mucositis, from your point of view, it's about really encouraging patients, but also just ensuring that any symptoms they have is reported efficiently to the nursing and medical team. So with diarrhoea, this is the final kind of side effect we're going to talk about, but diarrhoea is chemotherapy-induced diarrhoea is a common problem in patients, and it affects 60% of patients, and 10% of those have severe diarrhoea. It's related to an imbalance between the absorption and secretion of fluids within the GI tract. So risk factors for patients in developing diarrhoea, again, females, those of an older older age, depending on the patient's bowel pathology. If they've got a history of bowel issues, then they're more likely to develop issues with diarrhoea during chemo. Those that have got a lower performance status, so those patients who you know, have got a performance status of 2, so spend more time sat down or in bed. When patients are neutropenic, depending on what their diet and nutrition is doing, and also on what level of medications they're taking. So again, as a healthcare assessment, healthcare assistant assessment, what can you be doing? Well, helping patients and encouraging them to make sure their stool chart's completed. This is a real way for us to identify how many times a day patients are going and at what consistency that is. Ensuring we're monitoring their weight, what their urine colour's looking like, and what their blood pressure's doing. So these are really good ways for us to know how patients are doing and whether having diarrhoea is having any detriment effect to them in any other ways. Most importantly, collecting a stool sample. We need to do this at the earliest opportunity, and again, it's about encouraging patients to tell us early. And then making sure our patients are hydrated. Is the fluid chart filled in? One of the main reasons patients go to intensive care after having transplant chemo is because they become dehydrated. They then drop their potassium levels to a point where we need to put them on a cardiac monitor, which we're unable to do on Dove, and this is why they go to ITU. And also in ensuring you're filling in food charts and ensuring, you know, different menus are getting offered to patients. So there's lots of things as a healthcare assistant that you can be doing, and as part of when you're, you know, again, helping your patients with changing their beds, with washing and dressing, all of these things are really important, or just when you're in there chatting to them, really. So treatment for diarrhoea. Again, stool sample collection is vital. Until we've done that, we can't do anything else. Once we've done that and we've got a negative result, we can give them loperamide or Imodium. And it's really important that they're getting that regularly. So again, it's about encouraging the patients to ask for it should they need it. Once we've excluded any other infection, if we need to, we can replace fluids with intravenous replacement. And if patients have got a lot of abdominal pain, it's really important we do a CT or ultrasound scan of the abdomen. There is a risk that patients can get infections within the bowel, or they can get other complications. So it's just really important that, you know, if you're concerned that a patient's expressing they've got tummy pains, that you are feeding that back to the medical doctors so that they can arrange for scans if necessary after they've assessed the patient. So I think really what I wanted to highlight is that it's all our responsibilities to be supporting patients with these side effects. They are the most common side effects from transplant, generally because of the effects of what the chemo does to the body. They can generally start anywhere from the day of chemo up until the point of discharge. And it's just really important that you are aware of that, and that you, if you've got any concerns about patients, that you escalate that immediately. So thank you for listening. I hope you found that presentation useful, and as always, if you have any questions, please do not hesitate to ask.